All right, so we'll jump right into it. Thank you all for taking the time to join us today. I'm Cassie Bruce. I'm the manager of client engagement for PATH, which stands for Personalized Approach to Health. PATH is a joint venture between Baptist Health and the YMCA, and our goal is to help employers provide a safe, healthy workplace for their employees. So obviously, COVID-19 has totally disrupted our businesses, our communities, and our families. And because we don't have a magical cure, and at this point, we don't even have a vaccine, it's in our best interest to plan for prevention and take all the precautions that we can. So at Baptist Health and PATH, we're continuing to build resources to support your efforts in ensuring a safe workplace and community. So thank you to all of you who completed the survey when you registered. We're going to use your feedback to build upon our resources in order to make what we're providing the most valuable and meaningful for you and your employees. So I'm very excited and honored that Dr. Schlotzer is taking a few minutes out of her day to share the latest updates regarding COVID and answer the questions that you all submitted. And if you think of a question throughout the presentation that you didn't get a chance to share, feel free to use the chat feature. We are all going to be on mute, but if you just type in your question into the chat, we'll get to it if we have time at the end of the presentation. So to introduce our speaker for today, Lynsey Schlotzer is a family medical physician at Baptist Primary Care in South Ponte Vedra Beach. She's been practicing medicine in our community for about 5 years and recently opened up that new practice in Ponte Vedra Beach. She completed her residency at Mayo Clinic of Florida in family medicine and also completed a sports medicine fellowship at the University of Louisville in Kentucky. She spent the first 5 years of her career working in Chicago as a medical director of a large occupational health group. During this time, she served as the medical director for Metro Rail, which is the fourth biggest commuter rail system in the United States. In 2015, she made the decision to move back to Jacksonville so she didn't have to deal with snow. She had beautiful weather and more square footage for her family to live in. So with that, I'll turn it over to you, Dr. Schlotzer.
Thank you, Cassie, very much for that great introduction. So I'm happy to be here today. COVID-19, as she said, is a big topic and it's a hot topic. And I definitely want to touch on a few things before getting into the question and answer session that we're going to have. And I received a lot of great questions. There was a variety of questions ranging from testing all the way to prevention. So I'll try to get through as many as I can. To start briefly, I think, because of the profession that you guys are in, I want to definitely streamline this question and answer session more to have to do with employer side, employer base, what to do if someone does have COVID. So what I want to start with here is there's a lot of information that's been out there that's kind of misinformation about the transmission of COVID and people that would be deemed as higher risk. And what I'm going to focus on is more of the special circumstances and the exposures that you guys may be dealing with regularly, and kind of quickly update you on the latest CDC medical guidance regarding those circumstances, because believe it or not, the changes are rapid with the CDC. Everything that I'm going to be talking about almost will be coming from the CDC website. And if you've had a chance to look at this, which I hope you have, because there's just a vast amount of information. Everything that I have in all of these slides all came from the CDC website. Glad to give you the slides, but all of this is in that website if you need anything to use as your guidelines. So with these precautions that are listed, this is the OSHA guidelines for, what they're recommending pretty much to minimize risk of exposure. And you guys know these things, but I just want to touch on them. But frequent hand washing, disinfecting all surfaces. A big one is maintaining 6 feet of physical distance, and I will explain that more later. And again, use of masks or face coverings. Those two things in particular are going to play really big roles in exposure. And then obviously, if you can, which you always can't, you want to promote remote work when possible. And then the other side of this is more of a prevention side that we do in our hospital settings and clinics is to consider doing temperature screenings prior to reporting to the workplace when on site. And some places are even doing just attestations, having people write down before they walk in the building that they do not have a fever, they have no symptoms. So, on the other hand, obviously, you're still going to have people that have what we would call in the medical world is community exposure. In other words, you're doing everything you can in your work environment to keep people safe, but when they leave your environment, they're hanging out with friends, they're going home to their family. A lot of things can happen in the community that can cause exposure to happen. Although each circumstance is different, if someone was exposed outside the office and they're reporting it to you, obviously now you have to deal with it. I do believe that a test confirming they are not infected is recommended just because it's a little hard to be able to do contact tracing, with something that's not happening in your environment at work. If a person isn't sure if they need a test, then my advice is to have them contact their primary care physician, or if you guys have some type of medical person that's on staff or someone that you can go to for these questions to help out to get them back to work as soon as possible, but would be recommended. So on the next slide, they talk about a return to work plan. So initially, we heard a lot about testing. It was all about testing, getting a test to get people to return to work. And not only one test, but two tests 24 hours apart. They have updated their recommendations with this. They are now emphasizing what's called a symptom-based strategy for discontinuing home isolation for symptomatic persons with confirmed or suspected COVID-19. So what this means is that they were offering two different guidances. One was test guidance and the other was symptom based, where they said you could do the testing, but you could also just do it based on symptoms. Now the CDC is actually not recommending using testing as a way to get people back to work. And the reason why is that, as I listed here, it limits the new guidance limits unnecessary isolation. I mean, as you all know, getting a test has been kind of ridiculous lately, at least in the Northeast Florida area. Just to get an appointment for a test can take days, and then to get the results back at some facilities, they're quoting 7 to 10 days, which is absolutely just unacceptable for a return to work plan. So that's some of the main reasons for it. Other quick reasons I can tell you based on the research that I've done is that they think COVID-19 is the most transmissible and infectious within the first 5 days of exposure and having symptoms. And then they say that within 7 days is really the guideline. And because of that, they just said, let's make it 10. So they're thinking that for majority of patients, if not all of them, within the 10-day time frame, they are no longer going to be able to transmit this to someone else. So, and on the next page here, I want to show you the guidelines themselves, because I think these are ones that I really want to drive home, because these are the things you're going to be seeing, and these may be things you already know, but it's always good to review. So, if you have an employee in your office that has COVID, whether they were diagnosed outside of your office or outside of your facility, or they were diagnosed by someone in your facility, if they have mild to moderate illness, and what that means is maybe they have some symptoms, they're coughing a little, they have a fever, they're not feeling well, maybe they had an ER visit where they were sent home with some home oxygen, maybe. This would be in the category of mild to moderate illness. If they are not severely immunocompromised, and severely immunocompromised, we're talking about someone with HIV or that's on prolonged steroid use. Those would be people who are not severely immunocompromised. Now, I know a hot topic is the words high risk. You hear about patients who are high risk, obesity, people have diabetes, people over the age of 65. They are saying that these people are higher risk. That is not the same as severely immunocompromised. I want to make that clear. So even patients with diabetes or that are obese or that are over the age of 65, they would fit into this category if they have just some mild to moderate symptoms. If they are, if they have a test that confirms they're positive, and let's say they were sick for 2 days prior to their test, then they can start the clock as to the first day they had symptoms. So after 10 days have passed since symptoms first appeared, and if they haven't had a fever within 24 hours without the use of Tylenol or ibuprofen, then, and their symptoms have improved, that's a big one too, they can return to work safely based on the new CDC guidelines. Now, I will tell you that this patient might have a cough for a while. You know, your employee might be coughing, which makes a lot of people nervous. It doesn't mean that they don't still need to wear a mask and stay 6 feet away from everyone. But that is the guidelines. So that is a way to get people back to work in a timely fashion. And then on the next slide, we talk more about severe symptoms, which obviously, you know, severe to critical illness, we're talking about people that are hospitalized, maybe we're in the ICU. And we're also talking about those individuals who are severely immunocompromised. In other words, um, they have AIDS or HIV, or they have long-term steroid use. Now, I know you've probably heard some people talk in the news and stuff about people who are on Humira or some other type of rheumatologic medication or autoimmune medication, which suppresses your immune system. I also want to make it clear that that is not someone who's severely immunocompromised. So they would still fall in the other category, unless, of course, they were severely ill. Then they would fall in this category. So I hope that's clear. But then the guidelines change to 20 days. Nothing else changes. It just means from the day they started having symptoms, 20 days need to pass before they return to the workplace. And they also have to have no fever within 24 hours without fever reducing medications, and then their symptoms have to have improved. So obviously, this is a big change from what they were showing before. And then the only other thing I wanted to add is we're hearing a lot about patients that aren't even having symptoms. They're all of a sudden reporting saying to work that they can't come in because they're sick and they were just at work yesterday and had no symptoms whatsoever. So really the guidelines are that you base it on their test, and that's kind of the standard of care. So if someone is asymptomatic, but they find out that somehow they have a positive COVID test, maybe they were just interested in knowing what they came back with, or maybe they were around a friend who was around their brother, sister that had it, or, you know, you never know. If it comes back positive, at least 10 days need to pass since the date of their first positive viral diagnostic test before they return to the workplace. And again, if they're severely immunocompromised, like I mentioned, it will need to be 20 days. So hopefully that's clear. And if you guys have any questions regarding that, I mean, obviously, please let me know. There are a lot of employers out there, I can tell you, that are not keeping up with the guidelines, and they're still requiring testing in order to be cleared back to work. And usually in my practice, I will tell the patient what the guidelines show, but I usually almost always follow whatever the employer wants in their environment to go back to work. And so if they're requiring a test, then we do tests. So that's really all I had specifically about the guidelines. I want to get into the questions because I know I've already taken 15 minutes up just doing that. So what I would like to talk about, I'm going to kind of do this in a stepwise approach. One of the first questions I was asked that I want to address is Jacksonville in danger of being out of ICU space for COVID patients? I want to answer that with absolutely not. I've actually spoken with a lot of the people in charge of the hospitals around Jacksonville, and I can't give you exact numbers, but we are not even close to capacity. I saw some updated statistics within the past week for every hospital in the Jacksonville area. And just to give you a rough idea, there are about 60% of ICU beds available, just to give you an idea. Of those 40% that are being used, only 20% are COVID patients. And then of those 20% that are COVID patients in the ICU, only about 20% of them are on a ventilator. So that's just a really rough estimate, but that just kind of gives you a sense, because, you know, if you look at the news, you really have no idea what's going on. I mean, you can't keep track of it, even myself. So it was nice to see those numbers. But if you could show that slide, the next slide, this is something that was released from Baptist just yesterday, I think it was. This shows actually updated statistics that we have based on our 5 hospital system for the amount of COVID positive patients that are coming through our ER daily. So this is per day. So you can see from March, there was a little bit of a spike where we were having about 37 positive patients, and then it really really plateaued. And then, as you know, beginning of like the middle of June, moving into July, it's just kind of skyrocketed. And really, what this shows is a spike. But if you've noticed, there is a little bit of a downward trend. So we're kind of holding our breath and questioning whether this is maybe a sign that this is getting better. And it has been on a trend. And those little dotted lines are an indication of the statistics and what they would predict to happen. But obviously, statistics are just numbers, not people. So we update this every day, and it helps us understand what's going on in our community. So, okay, so moving on. Another question that was asked was, is there still a shortage of PPE for healthcare workers? This is kind of a loaded question. I will tell you that in the hospital setting, for sure, we are not seeing a PPE shortage. We are definitely cognizant and aware of the fact that we don't want to be wasting this stuff and we want to be careful with it, which is why we have a 90-day backup supply at all times for the N95 mask, goggles, face shields, gloves, all of that stuff. And then what we're doing at Baptist, and I can't really comment on any other hospital system, but I'm sure it's similar. We actually are keeping all of our PPE supplies at the hospital. So in other words, in the outpatient clinic settings, we do have small supplies, just in case we have someone that comes in, but we are not actively seeing COVID patients in our office because of that, because we don't want the hospitals to run out. So that's kind of where we are with that. We are trying to keep high-risk patients out of our office. And what I mean by high risk is someone that is high risk for COVID, just simply due to the fact that all the other illnesses of the United States aren't going away. It's just COVID's an extra layer that makes it a little more complicated. Another question that was asked was, is there a second wave coming? And that's kind of a generalized broad question too, but it is a very important question. I think it's on everyone's mind, is like, what's happening? We are still currently in what is considered the first wave. So Florida definitely could be included in what we would call a spike, but a fear of a second surge or a second wave could happen this fall, and that's the honest truth, as the temperatures drop and children start going back to school. And as we can tell, social distancing measures over time are decreasing. I did some research, and there was some cell phone data that was collected in a study which did show that social distancing practices are decreasing. So, as time goes on, people get more comfortable, they stop social distancing, and then things can happen. Both the flu pandemic from 1918, as well as H1N1 flu epidemic in 2009, if you could remember that, they had 2 surges. They had one in the spring and one in the fall. So if it falls into what we've seen with pandemic and epidemics in the past, this is something that could happen. But again, we just really don't know. But speaking of flu, though, I do want to comment that as a primary care provider, influenza is definitely on my list of worries. I think it's very important, if you have any ability in your job, to be able to encourage your employees to get the flu shot. If you have the ability to get a nurse on site to administer flu shots, or an incentive for people to get flu shots, I think if people are to get vaccinated, which I'm not really clear at this time whether I think people will be more likely to or less likely, but I'm inclined to think they'll be more likely to. It's going to be very confusing for a lot of physicians to be able to delineate whether this is COVID or flu, because as you know, the symptoms are very, very similar. But I do think overall, if your staff and your employees are vaccinated, you're going to see less viral illness problems in your environment. So definitely doing that could be a benefit. of working with a medical group to help with that as well. So next question. I see people wearing face shields in addition to masks. Are these effective in prevention of spread? Can't the virus get under the shield if they don't come low enough on the face or are open at the top? So the answer is yes. They definitely can protect, but they are not recommended by the CDC at this time. As per the CDC, they actually say they're currently not known. It's not known at this time if face shields can provide enough benefit as a source control to help from, spray of respiratory particles from other people. Another thing that we need to understand about wearing a mask or wearing a shield is that we need to make sure that we understand that the mask is not necessarily being worn to protect you. It's being worn to protect others. And that's a really big, and it only works really if both parties are wearing them. So that's kind of a hard thing to convince some people. So I definitely think the respiratory droplets can still get under the shield. So they do recommend if you're going to wear a shield that you still wear a mask. So then the question is, if you're going to wear a mask, why wear a shield? So I think it just depends on, I think it would be an extra layer of protection if that's something you wanted to do for other individuals, but not necessarily protecting you more, from what I can tell from what I've found. Now, it did say in independent studies that the respiratory droplets can get under the shield and it should never be used on its own. So the CDC recommendations is you cannot use a shield on its own for it to work the way it should. Okay, next question is, how soon to be tested after potential exposure? I've read 5 to 6 days, but should it be 14 to be sure? I think this is a really important question that unfortunately we do not have the answers to yet. There are some studies that will tell you that when you get COVID or you have inhaled respiratory droplets, that it may take a while before you present with symptoms. We do not yet have studies that show us that. If you look back at influenza, we have tons of studies on this. And actually, if you are in contact with someone with influenza and you sniff up respiratory droplets in your nose from being close to them, you can expect, if you sniff that up, that you should get sick between day 0 and day 4. And that's just the bottom line. And that makes it a lot easier to contact trace, because if you're all of a sudden sick, you can think back 4 days and say, well, who was I around? Who could have given me this? But with COVID, we do not yet know. So the recommendations are, if you're sick or have symptoms, go get tested. You don't wait to get tested, you just go get tested. And they do believe that most of the time these tests, even though it may be the first day of illness, they should come back positive. The question is whether you have these asymptomatic people that may have it, whether their RNA levels in their body are high enough to detect on swab. And we do not yet know that. But all I can tell you is that if you think there's symptoms or there is suspicion, go get a test and be tested as soon as possible. Don't wait until a certain amount of days thinking that might be more accurate at that time. And again, the 14 days to be sure, as I mentioned previously with the CDC recommendations, have now state that you should not be testing to clear people back to work, and you should not be testing again in order to make sure that they're not spreading it to others. The idea is, again, like I said, within day 7, majority, if not all, COVID symptomatic patients should be clear of spreading it to anyone else. So thinking of going 10 days is just to make sure that it won't be spread to others. So I see a quick question on here. Someone that has COVID can still transmit it weeks after. We have not seen this in clinical situations, and according to the CDC, they do not believe this is likely. So that's why it is safe to let someone go to work after 10 days of symptoms. All right, the other thing I want to talk to you quickly about is risk. Again, the high risk thing that I spoke of before. I want you guys to always be thinking about the fact that there are a couple of guidelines in place that you can always use and fall back on when you're confused about whether someone needs to be tested or whether they need to go see their doctor. First of all, face masks. If everyone is not wearing a face mask in your place of employment, there's huge risk. Okay, so if everyone is wearing a face mask 100% of the time and everyone stays social distance 6 feet away 100% of the time, then the likelihood of having a workplace exposure is very, very, very low according to the CDC. What happens is obviously you get these people that, they wear their mask like this, like the McDonald's drive-through that I was in yesterday, and then or wearing it on your nose. So if you are able to stress that in the workplace, then your workplace exposure will be extremely low. Now, if you have someone that or you have somewhere that it's not required to wear a mask in your workplace, then you are opening yourself up to some serious exposure risk. So the other thing that's very important to note is that if someone has been in contact with someone close where at least one person's not wearing a mask and they've been around each other for 15 minutes or more, that is considered a high risk exposure. So definitely putting any type of distance between people is important, but also keep in mind that the amount of time that you're around people in close proximity is also a very big risk factor. Okay, another question, and we can circle around to some of this stuff too. If we have an employee who tests positive, do we need to close down for 2 weeks? Referring back to those slides again, I mean, obviously, these updates have been changing rapidly, but contact tracing and identifying anyone who was in close personal contact, in other words, prolonged exposure, they're not wearing a mask, they're staying within 6 feet with the employee in a typical business setting, would be recommended. Now, again, if everyone has been wearing a mask and everyone's 6 feet apart, then obviously you won't have to deal with these types of situations because according to the CDC, you don't need to be doing anything huge. Now, if you have been in a situation with an employee where there's no masks are necessary and they're in close contact with each other, then the recommendation is that specific area that employee was working should be shut down. And anyone who was within 6 feet, prolonged periods of time, more than 15 minutes, and not wearing a mask, all of those people, it is recommended that they be tested. Now, if you shut down the area for 24 hours, then they recommend that you go in and disinfect. Now, some situations, depending on your workplace, that might not be an option. You may not be able to shut down your office or shut down your environment for an entire day until that work area is used again. And all the recommendations say is to clean the area as quickly as you can and as thorough as you can. And again, contact trace within 2 days of anyone that's been exposed to that person without a mask within 6 feet and more than 15 minutes of close personal contact should be tested and self-isolate until the results come back. If you do have a situation where everyone at your job is required to wear a mask, if someone is diagnosed with COVID and you were following the guidelines of the CDC, then the only person that needs to be tested would be someone that's not abiding by those CDC regulations. There's no one else that needs to be. So that's really your guideline. No mask, 15 minutes, 6 feet. If any of those have been broken, then within 2 days of when that person told you they were diagnosed or when they had symptoms will need to be contact traced back. So obviously with your jobs, that can be a lot. So when it comes to children, I want to move on to the next question. Are children asymptomatic carriers who carry and spread it to adults? This is a huge topic because obviously these kids are getting ready to go back to school, including mine. I want to say Duval County, I think, is the 20th, and St. Johns County is the 31st, and everyone, parents are just biting their nails. I will tell you that I have reviewed all of the guidelines, at least for St. Johns County, and they are following CDC guidelines to a T. They really are doing that, but obviously the question is, with my kindergartner, is he really going to wear a mask? Is he really going to do it? So, um, in the beginning stages of the pandemic, it really wasn't a question that was easily answered. And honestly, the kids were home. So kids weren't getting sick. They were at home with their parents. So what we were seeing more of is like the elderly or people at least over the age of 65 with comorbidities that were more prevalent. But again, some of that was that we didn't have as much testing. And of course, the media, the fear mongering and stuff in the media is always an issue too. Um, in most circumstances, the best way I can answer this question, in most circumstances, to prove a statement like children are asymptomatic carriers who spread it to adults, we would need to do like a cohort study for a prolonged period of time with a bunch of children, and scientists would have to be involved, and they would have to follow them over a time span and be able to watch and see and contact trace and figure out what percentage of children have COVID and test children when they have no symptoms. And honestly, we just don't have this information. I wish we did. My gut tells me that there is some of this happening, but obviously, until I see the research, I can't tell you for sure if they are actually carrying this to others. I did see a study recently that I found online last week that it was a small amount of children, but they did show that they had a higher propensity to have a higher viral load in their body, which usually higher viral load in the body can lead to more transmission, but that they were less likely to have symptoms from it. So that's kind of more of your asymptomatic carrier, right? But it was a very small study and I can't really comment on it more than that, but that remains to be seen. And I think honestly, once the kids go back to school, we're going to figure that out very fast. But we'll just have to see. I mean, obviously, my hope is that if everyone is social distancing and wearing masks, and the children are social distancing as much as possible and wearing masks, we may see less infectious diseases altogether. So we'll just have to see how that goes. Okay, moving on. Have any more insights into how long antibodies last in the body been made? This is really interesting to me. The antibody questions that interest me a lot. And then the question is how would someone who had COVID be tested for antibodies and then come back negative? And I actually have had this happen to a patient of mine. To give you a brief story, I had a patient that was extremely sick. She was in her late 20s with mild asthma and I did virtual visits with her every 3 days. She was on a bunch of oxygen and was very oxygen hungry. Her saturations were going down in the high 70s and she was scared to death. And we got her through it. She had a fever of 101 or higher for 40 days straight. It was a very serious case. It was obviously an exception. We're seeing a lot of people that aren't even having much symptoms, but these cases are out there and we're not quite sure why specifically, for instance, it happened to her. But she had a very, very serious case and I followed guidelines for antibody testing. And once she resolved, around the 2 to 3 week mark is when they recommend to do testing. And of course, I test her and she's negative for antibodies. And for me, that's very frustrating because I'm not quite sure what to do with that information. I don't know whether it was a false negative or whether the reason why she was so sick is because her body was not making antibodies. I'm just not quite sure. So there is a little bit of interim guidance from the CDC that honestly will probably change, but antibodies typically start developing around weeks 1 to 3 after infection. So in other words, usually, either after the date of the test or after symptoms start. The problem is we can't even say for sure if someone is immune after getting this antibody test. We don't know whether it means that your body has learned to fight it and it's just as good as a vaccine, or whether it means that, yeah, it recognizes it, but doesn't mean you can't get it again. So the question is not only does it make you immune, but how long does it make you immune? Um, Antibody tests should never be used to determine if someone should return to work. Antibody tests should also not be used, and this is a big one, to group people together in the future for like in jails or schools or dorms. Definitely not recommended by the CDC. And the other thing I want to add is with antibodies that you should know is that 1% of the time, well, let me back up. Coronaviruses have been around for a while. This is just a novel new one. But 1% of the time, the antibody test can test positive for antibodies, and it may be that you had a different strain of coronavirus over the past year, and it's not even COVID-19. So this antibody test is not 100% either for COVID-19. But 1% isn't that bad. I mean, I would love it if it was 100%, but 1% is not bad. So the other thing is we're not even sure if insurances are going to pick up the cost of these antibody tests. And I'm not sure about pricing, but they're probably ranging anywhere from $60 to $120 for the test. So, and then at the end of the day, it's just kind of a novel thing to find out, but it may or may not be helpful clinically in any way or with work. I mean, it doesn't really help you with work. So, okay, moving on. I've heard of people using nasal gels like Swipe Shield as an additional protectant against COVID-19. Does it work? I found this question really interesting because I have never heard of Swipe Shield. So I did a little digging, and unfortunately, there, from what I can read, there is no nasal gel protectant that has been proven or approved by the FDA to prevent COVID. That would be amazing. I mean, it sounds great. And just to give you a little background with Swipe Shield, about 10 years ago, there was a physician named Kent New who came out with this product and kind of marketed it as like an all natural nasal protectant gel for anyone over 2 years old. And you just swipe it in your nose 3 times a day, about 2 to 3 times a day in each nostril. There are 3 retailers in Jax that sell this. I looked that up too. And they've got some weird ingredients that I'm not a chemist, but it's called malic acid and sodium olein sulfate are the active ingredients that are supposed to protect. It states on, I guess, on the website that it will dramatically decrease your chance of illness. So it's kind of this more generalized, it will decrease illness. There's no stats on their website about COVID-19. However, there were quite a few tweets and Facebook posts stating that the product will kill coronavirus. Well, as soon as that happened, the FDA got involved. On June 30th, they sent them a cease and desist letter stating that their website as well as their tweets and Facebook were claiming false claims. Some of them even stated that it was FDA approved when it wasn't. And they warned them that it was unlawful to advertise a product that could prevent, treat, or cure human disease. And there's no, for right now, COVID-19, there's no such study that is currently known to exist for Swipe Shield. So tread lightly. I don't think this is something that would hurt you from what I can tell. But I mean, it might be worth trying, but obviously there's no studies that show that it's going to keep you from getting it. I wish there was. That would be great. Okay, and this is a really big question that's really hot topic for my patients. Is there truth to the statement that people with O blood do better with COVID? Now, I have heard a lot of talk about this, but to be honest, I haven't really looked into it a lot. And this question made me do a lot of digging. And surprisingly, the answer is very possibly. There were 4 or 5, let me see, 1, 2, 3. There's 4 studies that were done that I read. Not one of them in particular was published in the New England Journal of Medicine. And I'm just going to quote some facts for you just so you kind of know. All of these studies were either done in the US, England, or China. And each study usually studied about 2,000 to 3,000 people, patients that have COVID. Obviously, when you talk about studies, there's different setups for it, but some of them were done for very seriously ill patients. Others were done like in New York. The last one that was done at Columbia University with New York City population of people who just tested positive. They weren't in the hospital setting. And what it showed overall is that type O blood was anywhere between 20% and 45% less likely to get COVID. So that blew my mind. I was like, wow, this is crazy. I mean, there was even a study in US and China that was done showing that type O blood was associated with a 35% reduced risk of disease. So I guess the question is based on these studies, it seems more likely that you're, at least from these small studies, that you're less likely to be hospitalized and have a severe case. I don't know whether we can say you're less likely to acquire COVID, but you might be less likely to be hospitalized for COVID. And I'm saying this with a grain of salt because this is just the very tip of the iceberg with doing this testing. And there's probably so much more that we need to find out. And the only other thing I will say is it did show that type A blood average in each study was somewhere between 20 and 45% more likely to have serious disease. And then they mentioned in one of the studies in New York that type AB blood was 44% less likely to get COVID, but the other part is that AB blood is extremely rare, so maybe their numbers were lower, and they didn't comment on that. So bottom line is, very possible type O, if you have type O blood, you may be less likely to be really sick from this. Type A, you may be a little bit more likely to get sick from this. But again, there's a lot more studies that need to be done before making any final comments on that. And the other thing that's really huge for you to know is that these blood studies, you can't go to your primary and get these studies and have them covered by insurance. They're hundreds and hundreds of dollars. Everybody's asking me for type and cross. They want to know what their blood type is. But unfortunately, I think the test is somewhere around $300, $500. And insurance, no matter what I put as a diagnosis code, will not cover it. So as much as I would love for everyone to know their blood type, if you're going to do it through me, it's going to cost a lot of money. Now, they do have some in-home kits. I looked online. There are places you can actually purchase a blood type kit that you can do at home. It's a very simple thing to do. I remember doing it in microbiology class where you can figure it out. But to have it done by Quest Diagnostics or LabCorp, it's obviously a little harder to get covered, unless you don't care about price, which you may not. Quickly, another question that was asked, can a person get COVID-19 twice? I have not yet seen it. I have no colleagues that have seen it, but this is a hot question. We don't know. If it behaves similarly to other coronaviruses, what the CDC has said is that you might be immune for a while and then lose immunity after a few months, but studies are ongoing. We don't know. And then there were some questions about, I've had questions in my clinic about hydroxychloroquine. So the question is, how does it work? And bottom line with this is I did a lot of research on azithromycin, hydroxychloroquine, ribavirin, and all these different antivirals that are being tested, and none of them have overwhelmingly showed that they're safe. So they're not really recommending them, and they're only being given in the hospital setting too. So we have not even done research yet about hydroxychloroquine as an outpatient, like for people that have like mild symptoms. When you think about influenza, we have Tamiflu. I don't know if you've ever heard of that, but Tamiflu is an antiviral that's used. You come to the doctor's office, you're sick, we swab you, you have flu, take Tamiflu, it'll make the symptoms less severe and it shortens the amount of time you're sick. And the way you give it is you have to give it within the first few days of illness or it doesn't work. That's the kind of thing we need for for COVID-19, but we don't know what that is yet. And we have not done outpatient testing. We're still trying to figure out how to save people on the inpatient side. So there are ongoing studies, but giving hydroxychloroquine from my office to patients as an outpatient is something they are not recommending by the CDC. So Baptist as a whole, we've been told not to do this, and I think even pharmacies are denying doctors for patients to get this because of the increased risk of heart attack and cardiovascular disease that can occur from this. So stuff's ongoing. A last minute question that I got that I want to quickly touch on is how accurate is rapid testing? So PCR testing is the best test, okay? PCR, as you guys have probably heard, is that one that goes all the way up into your brain. You got to do the nasal pharyngeal way back here and hold it for 10 seconds. That is the one that is the most accurate. Unfortunately, the swabs themselves, as well as the labs that can run this specific test are bombarded and we're running out. So as time has passed, all of these laboratory corporations have come out with their own tests. So PCR is the most accurate, but a really close second is something called a molecular test. And the interesting thing about the molecular test is that there's about 5 or 6 different companies that have come out with this over the past month, where it has an emergency use authorization. In other words, the FDA has pushed it through to be able to be used. And the clinical trials and studies that have been done on this test show that it's around a 15-minute result, which is amazing. I mean, these PCR tests can take up to 10 days. It can be done in a clinic, so you can drive up. It's a self swab, so you don't have to go all the way up to your brain. It just goes on the outside and you swab your nasal passages. You put it in and you give it back. You wait in your car for 15 minutes, and then someone can call you or do a video chat with you and let you know the results. That molecular test, believe it or not, is being used more and more frequently. The self swab, where you just swab it yourself, I didn't know this, but has been used for a while at the federal testing sites. They have run out of the nasal pharyngeal swabs, so they are now doing PCR testing on the self swab. So some people think that's probably not as good of a test, but the statistics are pretty good for the PCR and molecular. They're pretty darn good. The only thing I will say about the molecular testing is it's only a good test if you're testing within the first 7 days, preferably 5 days of illness. And again, it shouldn't be used as a return to work test anyway, because we're not doing that anymore for CDC guidelines. But the molecular test isn't as accurate if you wait to the end of illness. So it's only really accurate those first 5 to 7 days. And then the last test that I want to mention to you is an antigen test. This test actually has a lot of false negatives. So people are getting negative results and thinking they're fine when they do in fact have it. My recommendation is if you can avoid an antigen test in any capacity, I would, and I definitely would not use that as a guide for returning to work. And the thing is you don't realize that all these places are using different types of testing, and it's really hard to figure out what tests they're using. So make sure if you have employees that are being tested, that you understand what the results are showing you, that it is a PCR test or a molecular test. And the antigen test, you have to understand, may not be as accurate.
Hey, Dr. Schlotzer. Just
Yes,
to confirm, are the antigen tests those that are distributed through the throat? Are those the throat swabs?
they are, but they also are some that are done in the nose too.
Okay.
Not always, the swab can't always tell you what test it is.
Would you say, okay, so they might be, even if you get a throat swab, depending on how the lab is processing it, that will determine how accurate it is?
Yeah, it depends on how it's being processed specifically. Yeah.
Okay, thanks.
So, and there's new tests coming out all the time with different people. Abbott Labs just came out with a molecular test. I know that McKesson is selling a few of them. So there's lots of different people that are kind of getting into the COVID-19 testing game, because obviously we need more testing. We need more doctors testing rather than people waiting hours and hours in line to get a test. It's just ridiculous. So it's happening quickly. I think pretty soon we're going to see a lot more places with availability to be able to test and do it in a rapid way. So that's the good news. I think that's all I really had. I do just want to say, and I'll go over any other questions, but I do recommend for you guys that you have a close relationship with with a medical, a medical community or a medical group. It's just, the idea of, being in HR or being in employee health and not having, a go-to physician or a go-to group to go to kind of, talk about these questions. I mean, at Baptist, we have a nursing hotline that employees call, a COVID-19. Like if I right now feel sick, I can call and report it. The nurse will talk me through it, will help find places for me to get testing. And then after, I get it set up, they'll follow me through and make sure it gets done. And, this is kind of some of the stuff that PATH does, through Baptist is they can, provide this kind of thing where you can have a hotline for employees to call that can kind of help triage these complicated cases or when you're not sure. And then the other part of this is the prevention side. I mean, being able to prevent some of this by either doing thermal scanners or attestations coming in the door, people having to say how they're feeling, and or even having a temperature check. I mean, can be, believe it or not, it seems so simple, but it really does make a difference. And I see, it looks like one of the questions up here said, no mandate to wear a mask while at work. And it says how safe to use communal bathroom. So this is what on OSHA website, the OSHA guidelines, they do talk about bathrooms and how this obviously is an enclosed space and can be very difficult. But the advice is just to make sure that if you feel like you're walking in there and there's a bunch of people, you may want to wait. And I would recommend that everyone wear a mask. I mean, you lower your chance of transmission so much by doing that. How safe to fly domestically right now? Yeah. Well, I don't know if I can tell you that. I haven't done it. I have patients that have told me that the flights are empty. So I guess in that regard, it's good. I know that they have filtering air systems when you're on the plane, but bottom line is if you're in an enclosed space for prolonged periods of time with people you don't know that you can't trust on whether they're wearing a mask, you're going to be more at risk. So I don't know if I can say how safe it is, but I wouldn't say you shouldn't fly, but I definitely think you should try to take precautions as much as you can. And but you don't know who you're going to be sitting next to. So it's kind of a crazy time with that. And I think the airlines probably are following CDC guidelines as much as they can too, but when you're dealing with enclosed area, you can't guarantee that physical distance, and that's huge. So let's see. Do you recommend that employees see their primary care doctor first if they are experiencing COVID symptoms, or go to get tested at a testing site? Okay. So the CDC actually does not recommend that an employee see their primary care doctor. I have to say I don't agree with this, but they feel like it will bombard the medical system if every employee health group were to tell an employee who has symptoms to make an appointment with their doctor and to require a doctor's note. They feel like that's not necessary. I think it depends on severity of symptoms. I think number one, if the employee is super concerned, they have other medical problems, then yeah, definitely would recommend that they see their doctor. If they are kind of refusing to go get a test and they're symptomatic, they need to see their doctor to kind of figure out whether it's needed. In that situation, if you have concerns based on, the safety of your environment, then I think that getting a doctor's note, clearing them back to work would be recommended as well. But if they're just, if they're just having a cough or a runny nose and they're concerned, I think that taking them off of work self-quarantine and have them be tested as soon as possible would be recommended. But keep in mind, the big part of this is if you aren't in a situation where you're attached to a medical group that can get you rapid testing, I mean, this person, if they live in, let's say, St. Johns County, there's one testing site federally that they can go to. And let's say a hurricane's coming, they have nowhere to go. So you might have that person off work for days just waiting for testing, and now you're waiting for results. So that definitely is, I mean, it's still the same stuff I'm dealing with here in the office. It's very frustrating. So we definitely need to get more testing. And I think if you have any type of ability to get rapid testing, I would recommend it because it's definitely been difficult to get people to go to these federal testing sites for lots of reasons that everyone already kind of knows. So, um, let's see, did I answer all the questions?
I had a couple come through on my end.
Okay.
Um, Someone asked, does your blood type show up on routine blood draw tests?
No, it doesn't. I wish it did. No, it's actually a very specialized reagent that's used to be able to identify the type. It's a special test in a special tube all its own. So no matter what blood draws you've ever had, likelihood of you having a type, a blood type test is very low unless you're a female and you've recently had a baby. You can get your gynecologic obstetric hospital records, and I guarantee it's in there. Or if you've had major surgery, they usually will type and cross your blood. And so in the hospital setting, I think is where you would see it more. Or maybe in your gynecologist's office, because when you have a baby, they need to know your blood type in order to make sure that you're safe to carry the baby without getting what's called a ROGAM shot. So,
We
but
had someone in the chat said if you donate blood, sometimes they'll tell you your blood type too.
oh,
That
okay.
might be a shortcut.
Yeah, yeah, that would be good. Hey, there you go. Donate blood.
Two birds with one stone.
Yeah. Give back to the community and find out. See? Yeah.
Exactly. And we
Yeah.
have one more question. Should individuals be focused on building their immune system to combat COVID?
I definitely think that's important. I mean, again, I'm saying it kind of as a, what's the word I'm looking for? A generalized statement, but I think we can all agree. And also, there have been studies that show increased stress, lack of sleep, poor diet. All of these things do lead to more likely to have infectious disease and also more likely to have worse symptoms. Now, I don't know whether I can tell you that if your immune system is boosted by getting lots of sleep, lowering your stress level, taking a multivitamin, maybe zinc, if you're feeling sick, can help sometimes. I can't say that you'll be less likely to get COVID, but your symptoms might be less severe. You know what I mean? Like if you're taking care of yourself. But I do think that always should be a focus. I mean, gosh, I mean, we're going into the fall here. I mean, it's I'm just not quite sure what to expect, but every fall, I mean, I get bombarded with infectious disease in my office. And I do expect that to happen again. And we just need to do all we can to prevent, in any way we can. So, anyone else have any questions?
I think that's all I'm seeing in the chat box. We can give it a couple seconds, but we are coming right up on 2 o'clock. Want to respect everyone's time. Thank you so much, Dr. Schlotzer, for all this information.
It's a lot. And I mean, I could talk about this for like literally like 3 more hours. I will tell you the majority of what I said, though, is in the CDC website, but it's just, it took me hours to look through it, and it's still, I have to constantly look at it because it's updated constantly. So, but there are some good resources on there. I know that PATH has good resources too that show a lot of good recommendations based on CDC and OSHA recommendations. And the other thing, just to quickly tell you, you want to make sure through all of this that you are keeping patient confidentiality at the forefront. You can't be screaming and yelling to everyone that Jack just got COVID. We do encourage, at least through Baptist, I know Employee Health encourages people who have COVID and have had it in the workplace to disclose that information and allow Employee Health to disclose that information. But if they are adamant they want no one to know, then you have to tread really lightly. It doesn't mean you can't let people know that someone who's been in your environment has had COVID, but you just have to make sure patient confidentiality is kept. As you guys know this stuff.
Yeah.
So,
We had one request to quickly reiterate one more time. So, what's the guidance on returning to work since it's not based on testing?
all right. So can you pull up the slide again for
Let
mild
me
to moderate illness? Okay, and you got to go back a few slides.
So we'll go
There
most.
we go, right there. Okay, so patients with mild to moderate illness, these are your patients that cough, flu-like symptoms, abdominal pain, sore throat, fever, malaise, tired, achy, not hospitalized. Those people would need to wait 10 days from the day they started feeling sick before they can return to work. Okay. In addition, they also have to have at least 24 hours have passed from their last fever. A fever is diagnosed as 100 degrees or higher without Tylenol or Advil. And obviously, some of this is taking their word for it. And I do understand that's a limitation. And then also, their symptoms need to have improved. And then the other thing I will say is that these are people we're talking about that are not severely immunocompromised with underlying medical conditions that severely compromise their immunity, such as AIDS, HIV, or prolonged steroid use with steroids higher than 30 milligrams of prednisone a day, which is kind of specific, but we're not talking about people on Humira or people that take rheumatologic medications that can suppress your immune system. That is not a severely immunocompromised person. So they would still fall into this category. And then the next slide would be your individuals who are extremely ill and are hospitalized or intubated, and they're in the ICU, and or your individuals that are severely immunocompromised that I mentioned. Those individuals need to wait 20 days from the time they started feeling ill before they go back to work. They also need the same guidelines. 24 hours have passed since last fever without the use of fever reducing medications, and their symptoms need to have improved. You guys need to keep in mind, though, that if someone was severe to critical, specifically in the hospital, they may cough for 2 months. That does not mean that they're transmitting COVID to employees. That doesn't mean they don't need to wear a mask. I do recommend that. But at the same time, if it's not mandated at your office, that is something that, human resource wise, that you'll have to deal with. But wearing a mask, everyone involved at your office or in your environment, if they're wearing a mask, you're going to decrease your transmission substantially.
Awesome. Thank you so much. And
All
thank you
right,
to everyone for joining us. This has been super informative. We really appreciate it, Dr. Schlotzer.
no problem. Take care.
Thanks. So we'll send out slides, recording, and the link to the CDC guidelines, as well as Pass Back to Work playbook.
All right.
Great. Have a great day, everyone.
Take care.